everyone. First off, I would like to thank you all so much for joining us and spending this part of your evening learning about risk assessment and prevention. Just a housekeeping items before we get started here. You are all muted, so we can't hear verbally any comments or questions. So if you do have any questions, please type those into the Q&A box on the right-hand side of your screen. And you also need to escape out of full screen mode to see that box. And at the end of the presentation, we will have about 10 minutes to answer questions. If we don't get to them all, we will be replying to those throughout the remainder of the week via email. And last but not least, the webinar will also be recorded. You will be sent a follow-up email with the link tomorrow, so you guys can view it at any time or share it with colleagues. So with that, I would like to go ahead and introduce Dr. Kim Kutsch, CEO and founder of Oral Biotech, manufacturers of the CariFree system. Dr. Kutsch has been successfully practicing dentistry for over 30 years and still practices 3 weeks here in Albany, Oregon. An incredible passion for what he does and his vision to create effective camera protocols, which continues to drive him in his research to improve caries diagnosis and treatment. So Dr. Kutsch, I will let you take it from here.
All right, Kendall, thank you so much, and welcome everybody tonight to our continuing series in camera and how you use the care system. And we're going to continue on the diagnosis pathway. And actually, I lied. We don't have 10 new CariFree cases for you tonight. I actually have a bonus. We're going to have 11 cases. So, and I think I've got kind of a diversity of different types of cases, things that, these are real patients from my practice, things that you're going to see in your own practice, and just continue to give you more and more background on, what types of questions, what kind of things to look for as you go through your diagnosis to try and identify what's driving the disease for those individuals. Always is, this is a young man that came to me a few years ago, and, in this condition, and through my entire routine, I know this will be review. A little bit of the start here will be review, but we've got a lot of new attendees tonight, and young man came, he was 21 years old, came to my practice, obviously had a serious decay issue going on, and I went through my normal routine of risk assessment and had a consultation with him, and somehow, with my skill, quite get through to this patient at that point in time. And I think that's one of the things we have to recognize is that you can't coach somebody that doesn't want to be coached. You can't help somebody that doesn't want to be helped. And it isn't always us. It's, oftentimes it's what's going on in their life. But back to me, I didn't get to see him for another year. And this was just like 1 year later. Presented in this condition, and at this point in time now, you can see I'm building an Essex retainer tray, trying to get him on our fluoride gel, the fluoride gel at night, trying just desperately to save his lower teeth, and ended up with an upper denture. I mean, I wasn't able to salvage, and he wasn't interested in trying to do what it would take to save his upper teeth. So here he is, today. Now, a couple years later, managed to save all of his lower teeth. And he's decay-free, and I've been able to get through to him earlier in the process. I'd like to think that I could have saved those upper teeth as well, but these are the kind of patients I know that you see, I see. I tell you, I've seen new patients this week, and I have been one patient after another that have serious decay issues, and being able to sit down confidently with them and go through a risk assessment and talk about the usual suspects that are driving their disease, and the fact that typically it's only 1 or 2 things that we need to tweak in terms of behavior to help them is going to shift the balance for them, tip the scales back in their favor, and then being able to help neutralize and raise the pH in their mouth and use some products that will do that. We'll let them become decay-free, set them on the pathway to health. And literally, one of the and I think that I certainly played a role in this, as all of us have with cameras. We've made it too complicated. It's too confusing. I continually have heard that over the last 10 or 12 years. I tried it. It was too hard. I couldn't implement it into my practice. And so, that's one of the things that we've really worked on here and our practices. But I think of the roadmap for camera, and it looks like this to me, and it kind of makes your head spin. And it gets complicated and confusing, and oftentimes we try and make it more complicated than it needs to be. And if we're ever going to implement anything into our practices, it has to be simple because we're all busy. We have staffs that they're busy. They all have responsibilities, and to take on a new system or new responsibility in our practice is a challenge. And so the simpler that we can keep it, the better. Challenges that we run across, and my friends in academia hate that I talk about this, but one of the problems that we have to confront, I can be honest about how we view our research. You and I all want to practice evidence-based dentistry, and how we interpret our evidence base is a little different from how we interpret it in academia or in the research world. Academia looks at cross-sections of large populations. We get these large cohort studies and start talking about percentages of this and percentages of that. Looking at cross-sectionally at a large group of people. When you sit down with a patient, you don't look at a patient that way and think, well, you have a 32% risk of getting a new cavity next year. You're starting to look at longitudinally on this individual, and we're not talking about how does this affect the population of people. No, I have to make a decision for this person, and this person could well be in my practice for 20 years or 30 years or longer, and that I've done the right thing for that person longitudinally, because they're going to hold me responsible. If they have a problem, they're going to look to me and go, Doc, what kind of was that? That didn't work, or whatever those issues were. So I'm looking at the patients differently. So when I take that evidence base, I kind of start to apply it to my individual patient longitudinally. And a good example of that is a study that was published just last JADA, where they looked at sealing over non-cavitated carious lesions, and so be up to an IC-DOS category 2, and they did a survey and found that while our evidence base supports statistically that we should all be doing that routinely, that really there were very low percentages of dentists that were comfortable doing that. And the reason for that is you and I sit and look at that evidence, and that's all well and good, but the problem is I'm sitting with the patient who's in my chair, and I look at their caries risk, and I look at that lesion, and I may not be comfortable sealing over that, that particular individual, because I know that I'm responsible for this person's care for a long period of time. And we're not talking now percentages. I'm talking about they're going to get a cavity or they're not. It's all or none phenomena, and it's a longitudinal issue. So as we look at our evidence base and we apply it, I think we need to be real with the fact that we apply it as practitioners maybe a little different than we like to think of it or look at in the academic or the research world. And this was really a great paper published last year that highlighted the fact that we look at these things from different aspects. So one of the things that I started to do earlier this year, and I think it's really helped a lot of practitioners, dentists and hygienists, is to start, instead of thinking about how complicated this can be, and we look at these risk assessment forms, and I have to tell you, I have seen risk assessment forms that were 4 or 5 pages long. They had you add up and subtract and divide and do all of these things, and nobody's going to do that in private practice. We need to get about how can we sit down with the patient and in real terms, in a simple manner that they're going to understand, and do that in a time-efficient manner. And so one of the things I started with is, the usual suspects. I would just tell you from my experience at doing risk assessment, really when I get to the bottom line for an individual patient who has high risk for dental caries or is at risk for this disease, typically it comes down to just like one thing that's going on that's helping fuel this disease for them. They have one primary risk that's really creating the issue for them, or maybe it's a combination of 2, but it's not a complex thing of like they have 18 different risks and we have to go deal with all of those. It really comes down basically to primarily 1 or 2 of the, and I'm calling them the usual suspects, and if you can just cut to the chase for the patient, they're not overwhelmed by I have to make 15 behavioral changes and I have to do 16 new things during the day and use all these different products. It really comes down to, let's sit down and figure out which of the usual suspects it is for you. And so it really comes down to, in my mind, bacteria. And in bacteria, they either have too much bacteria or they have the wrong bacteria growing on their teeth. Or it comes down to diet. And a dietary issue, they either have too much sugar in their diet or they're eating too frequently. And we see if snacking is more important than what they snack on. And again, pH phenomenon. Or it comes down to saliva. And in that suspect is they don't have enough saliva for one of a lot of different reasons, but they have xerostomia, and xerostomia is a real issue. Now I've got the wild card there with and we're going to look at a couple wild cards tonight because I know that you're going to see some of those. But as we look at acid erosion and how that relates to dental caries or some of the clinical appearances that we see, but at the end of the day, it all comes down to Kaiser-Sose. It all boils down to pH. This is a pH-specific disease. If you have prolonged periods of low pH in the mouth that result in net mineral loss that's by a bacterial biome, you have dental caries. And if you don't have that condition, you don't have that disease. So it's really, I like to look at the patients and start to diagnose them. I mean, when you look at them, you see a lot of bacteria, a lot of plaque on the teeth. You can talk about diet. Do you see saliva? If they have absence of saliva, I begin to immediately to suspect that. So you can start to kind of direct your questions as you're going through the risk assessment, and we're going to talk about how to start asking those questions. As I continue on this series, the next step for us is going to be, okay, now what do we do in terms of treatment, and how do we phase treatment for these patients? How do we schedule that? What to do first, I'm going to go through in a practical manner and take some case again, and we're going to go through staging of treatment for those patients. And then we're going to, later this year, we're going to get into the coaching, like how do you help this person make those, maybe it's only one behavioral change, but how do you coach that person to help them be successful at creating sustainable long-term behavioral change for themselves? Because the most difficult thing in the world is affecting long-term human behavioral change. So that's what we start with. Here's patient number one. Now, the first thing I tell you to look at is, here's a 40-year-old female. She's not taking any medication. She has normal pulse and blood pressure. And I'm looking at this mouth, and I go, I don't see any plaque, right? The teeth, I see saliva. So immediately I'm thinking, okay, these look pretty good. I haven't looked at the x-rays yet. I haven't looked at anything else. But as I look at the teeth, just look at the mouth, I'm thinking bacteria kind of out the window and saliva kind of out the window if this person has a problem. So I can immediately start eliminating some of those things. I see a little marginal gingival inflammation there on 23 and 26. But as the teeth, things look pretty healthy here. We look at the radiographs. I look, wow, this person's never had a filling that I can detect. Doesn't have any decay. Got a little bone loss just in a few areas, but other than that, this patient looks pretty healthy from that standpoint. We look at the risk assessment form, and this is the new form, and I know that a number of you have already been using this for this year, and to some people tonight this is brand new. But the first three questions at the top, and literally let me explain the form quicker, the patient fills out the top half of this form down to the gray line, horizontal gray line, and then the dental professional fills out below that. Now, for this first patient, they circle, and we have them fill this out in the waiting room or in the reception area so that, it doesn't create a capacity issue in the hygiene department. We're expecting the hygiene department to take 5 minutes to fill this form out. But the three questions are basically motivational interview-based questions. I want to know, where is this patient at? Is this something they're willing to do? It's kind of the will do, can do, and won't do. So I know right out of the gate, this is a person that's interested in this. I can talk to them about it. And if they know it, that also opens the door to me to say, gee, I find that interesting that you came to see us today, and I've got a simple test I can do to test you for the bacteria that cause cavities, and you weren't interested. Can you tell me more about that? And a lot of people have fear, and even free on my forms, patients still ask me, well, how much is that going to cost? Which that always seems crazy to me. But anyway, so the first three questions are really about motivation. I want to know, are you interested in a free screening to test for these bacteria? Are you willing to talk about it? And I think that patients are very optimistic about the ability for them to change their diet easily. But I find that the top three questions, that kind of gets the ball rolling. And we also found that identifying the most important risk factors for those patients and having them actually self-identify, rather than me looking at you and say, gee, it looks like you have plaque buildup on your teeth, and have the patient go, oh, I don't think I have plaque buildup on my teeth, in their voice inside their head, or gee, it looks like you have a dry mouth, or to have the patient think, I don't think I have a dry mouth. Me telling you about a problem that I see that I think you have versus a problem that you identify that you think you have that you're telling me about are on opposite ends of the spectrum. And I have to tell you that this is really, really important with this form. Having that patient self-report those risk factors is huge. In terms also of being able to open the question, let's talk about that. I noticed that you say you have a dry mouth. Tell me about that. And the things that I like to use, and this comes from the coaching, and I want you to pick this up and start practicing with this as you go through these forms with your patients. Start to use the phrase, tell me about that, because it's absolutely non-judgmental. It doesn't imply that there's a right answer or a wrong answer. People enjoy talking about themselves, and if showing interest in them, gee, that's interesting, tell me about that. They'll give you the honest truth. They'll tell you what they snack on. They'll tell you what's going on. And an important phrase for you to just start playing with, and you'll be surprised at how people open up. If you ask them how many times they brush and floss and what things they snack on, they know the right answers. They're going to give you the right answers. Nobody wants to look stupid. I mean, that's just human nature. So if you really want to get past that, instead of asking those questions, just say, that's interesting. I noticed that you feel like you have a dry mouth. Tell me about that. Say, I noticed I wake up in the middle of the night and I'm breathing my mouth and my mouth is really dry. And I've just been noticing this recently. And, so I have an open door to start discussing that with them and helping them. So that's a phrase that I want you to just write that down tonight. And if you think about it tomorrow, the next day, and you're talking to a patient, start using the phrase, tell me about that, and see what happens with that. Anyway, so this person has no risk factors. Then either the hygienist or the dentist is then filling out they have no disease indicators here. This person doesn't, this woman. And the disease indicators, the thing that you're going to recognize, these have changed. It's new or progressing visible cavitations, new or progressing approximal radiographic radiolucencies, and that means penetrating the DEJ. So they're E1 or E2 lesions. They don't qualify there. They need to have penetrated the DEJ and be D1 lesions, essentially. Newer progressing visible cavitations, that just means cavities. When you look in the patient's mouth, you can see holes in their teeth. Newer active white spot lesions. An active white spot lesion is a dull white spot. If it's shiny, that's one that is inactive or has been remineralized. And then the last question is, most of the data, the research that's been done is cavity in the last year, has they had a cavity in the last 3 years, and those results are kind of all over the board. I really just want to know, has this patient had a day history and is concerned to you? And I want you to use some strategic thinking on that. The piece of this is the third part then is the biofilm challenge. And for this person, they have a biofilm challenge. So as we then go to an assessment, this person has no risk factors, they have no disease indicators, they have a low biofilm challenge, and there are no usual suspects. So this person is healthy. In terms of diagnosis, this would be a type 1 patient who is low risk. If you want it to be follow a recommended therapy, we'd recommend that they would use just like the CTx4 gel 5000, the 5 million fluid, just as a safe preventive measure for them. But basically, this is a person who is healthy. This patient, when you're looking at the teeth, and for what do I see in the mouth? Wet. I don't see much bacteria on there, so I'm thinking of usual suspect bacteria. No, I'm kind of not thinking that. Saliva, I'm not thinking that either. So here is a 53-year-old woman taking a few different medications. A couple of Sectral and Xanax do contribute to xerostomia, so that may be a bit of an issue here. Certainly the blood pulse are within normal limitations. When we look at the radiographs, there's some margins I don't like on a couple of those restorations, but that's not deep. So as I'm looking at this patient's mouth, I'm not really seeing any, let's go back here for a second. I don't see any white spot lesions. So when you start thinking about disease indicators, white spot lesions, visible cavitations, radiographic lesions, okay, the person's had some decay in the past, hasn't had a cavity, she tells me, for a number of years. So right at the moment, about her decay history. So look at the risk assessment form. She wanted to have the screening. You can go run the form and see that she scored a 606, which is below 1,500, which is pretty much the breaking point for separating people into low risk and high risk for this disease. And we then look down the risk factors, and she identifies multiple risk factors. She notices plaque buildup on her teeth. I'm concerned about that because I really don't see much. I think she's doing a really good job of keeping her teeth clean. She identifies that she has a dry mouth at night. Says she's not taking any medications. However, there are 4 listed in her medical history. So it gives you an opportunity to say, gee, I noticed that you're taking a couple of these, and then that gives the patient the opportunity. Tell me about that. You answered no here. Tell me about that. Oh, yeah, I haven't taken those for a while. Those are in my medical history. I took them, a couple of years ago or whatever. But it gives you the opportunity to open that door and discuss that. Do you drink things other than water? She's drinking coffee and what have you. And then, she snacks between meals. Tell me about that. Well, she's snacking frequently during the day. She's on a 5+1. She has a history of snacking. She's always eaten small meals. She's always snacked kind of continuously throughout the day. And she is now fast diet, trying to lose weight, and it seems to work for her. And she's also had some acid reflux in the past. So as we go through that, she's got quite a few significant risk factors. As no disease indicators at the moment, and she has a low biofilm challenge. So as we go to her assessment then, and we look at that, her risk factors are a concern to me. The fact that she's got a little bit of dry mouth. So as I start talking about usual suspects here, she's identifying that she has a little bit of a dry mouth. When she told that, it was primarily at night. She doesn't have any disease indicators, and she has a low biofilm challenge. So as we talk about the usual suspects, I think the most significant suspect for this person is her dietary habit at the moment. And so she and I discussed that. It's like, I don't want you to stop doing what you're doing, but let's just kind of account for that. So you're on the MetaFast diet at the moment. You're eating 5 small meals during the day. They're kind of carbohydrates. They're kind of low caloric. But again, every time we eat, the pH in the mouth drops, and eat or snack is more important than what you're snacking on. Our research is clear about that. And she's having the lean and green meal at night. Okay, this is wonderful, and she's lost weight. Okay, so I don't want you to stop doing that. Let's tweak it so that it works for you. There's several ways that you can do that. Just a simple remedy for you is when you take your MetaFast snack during the day or whatever else you're snacking on, just rinse your mouth out with tap water. Instead of diet soda or maybe coffee or whatever else you've been doing, just rinse your mouth with tap water. That's the simplest thing to do. If you want to raise the pH in your mouth, we have other opportunity. We have products that can do that. I think you should recommend that you're using those products to brush your teeth with, but you don't have disease indicators at the moment. But there's just a simple thing. Let's not change your dietary habits. Let's figure out how to do that safely and not contribute to your decay risk. So as with diagnosis here, this person would fall into a type 2. She's moderate risk. Usual suspects, I think primarily it's diet for her. I do see some saliva, and it's just simple to counsel or talk to the patient about that. So rather than saying you have these things that you have to do, let's pick one and start with that, and let's just try one thing. And that's one of the other secrets, I think, to being successful at anything that we do in terms of behavioral change, and certainly in coaching we recognize, even though if you have 6 things that this patient needs to change, pick one. And start with one thing. It's a lot more successful. You're going to be more successful changing one thing than trying to change 6 all at one time. And then you can just slowly work your way through those. And the other thing is, let the patient pick what it is. Like if, here I really only have one thing for her, but if there are 3 or 4 different things, and I had a new patient, a guy today, we have 3 or 4 things that he needs to change. I said, which one would you like to work on first? And he told me. And so I'm going to go with that. And he goes, well, what's this? And I said, no, we can do that later. Let's on this one first, and let's see how that goes, and I'll coach you along the way. And then when you're comfortable, you're doing okay with that, then we'll start working on the next one. We don't have to do this overnight. You don't have to make 10 beers at one time, because that, quite frankly, isn't going to work. So number 3, we've got a 1-year-old female. She's on a number of medications. I have to tell you that all 4 of those would lead to xerostomia. I'm looking, her tissue looks pretty dry here. The teeth are tiny, not seeing a lot of saliva. So right out of the gate, I'm looking at this going, boy, she looks pretty dry. I don't see plaque on her teeth. As I'm thinking bacteria, not seeing a lot of buildup of plaque on her teeth. I don't know what her diet's like here, but I'm thinking immediately, I'm kind of to looking at her medical history and medications, and I'm thinking that. I look at her radiographs, and here's a person that doesn't receive lesions. I don't see anything there going on. A couple of margins again that maybe aren't perfect, but here's a patient I'm going to sit down and go through and say, when we look at the risk assessment form, I get down to disease indicators, the answer is going to be no there for me. So here's a person who answered yes. She's very interested in knowing what's causing the disease that she's had in the past. She wants to talk about it, and she's willing to talk about changing her diet habits if necessary. She notices and reports that she noticed the plaque buildup on her teeth between meals or between she's taking a number of medications, and she also reports that she feels like she has a dry mouth. And again, this patient also reports she notices acid reflux as well. So I've got several factors here that stand out. The ones that I think concern me the most are the medications. We're not taking her off of her medications, but if she's got a dry mouth as a result of that, and that's contributing to her risk for this disease, while she doesn't currently have any disease, she's at risk, and she has a low biofilm challenge at the moment. Again, this is a patient then that risk factors are a concern to me. The disease indicators are not a concern. She doesn't have any. She has low biofilm challenge. We'll talk about the usual suspects here. The one that really stands out for me is saliva. So I think this patient is really dealing with medication-induced xerostomia. It's enough to tip the balance for her to put her at risk. She currently doesn't have any active disease, but it puts her at risk. And so, we have the opportunity to talk to the patient about how to manage that risk, because long term, if we leave you at risk for this disease, if your biofilm challenge increases, you certainly may develop some cavities or decay. So diagnosis on this patient, again, this is a type 2 moderate risk, a different usual suspect than the one before, which is primarily diet. Again, here's a patient now, they've got a dry mouth. How do you deal with that? Again, you'd want to look at putting them on a neutralizing 5,000 part per million fluoride. That would probably be the safest thing for them to start using instead of dentifrice that they're currently using. And taking off her medications, so something like a boost spray that's going to elevate the pH, or some xylitol gum that elevates the pH in the mouth as well throughout the day, may be enough just to kind of help risk. We're not trying to cure any disease here. She's just at risk for this disease at the moment. Now, this is a patient that to me about 2 years ago. And, my issue is I'm having a hard time chewing. 48-year-old male, really warm, amiable individual, sitting and discussing it with him. He has had pressure. Currently, and he's taking medications for that. He's currently taking Lipitor for cholesterol, and so his pulse is 71. His blood pressure is still just slightly elevated, although it's within an acceptable range. But we sit down and start looking at him. I'm looking at the radiographs, and I see a lot of tooth structure missing. And so you start asking the question, okay, why do his teeth look like this? What's going on here? So, assessment form, and he's interested in screening tests. He's interested in doing it, and he's potentially interested in changing his diet if necessary. This is interesting. So he's taking medications. He listed about 3 or 4 different medications, primarily for blood pressure and hyperlipidemia. And he feels like he has a dry mouth at different times during the day. And I'm asking him about GERD, because I'm trying to look at these teeth, and let's go back here for a second, and you look at the teeth, you look at this appearance. I don't see, let's talk about the usual suspects. see on his teeth? Well, I really don't see any. What's his diet? And I started, asking him questions. Tell me how you eat. Tell me how many times you eat during the day. Tell me about that. What kind of foods do you like? How do you describe your diet? Everything seemed pretty normal as I'm going through the diet. I get his historical photos. I want to know how active this is. Like, how long have your teeth looked like this? What did they look like 5 years ago? What's happening now? What's contributing to this? And then you look at saliva, and his mouth looks a little dry, but I see saliva pooling in the back of his mouth. So as you start thinking about usual suspects, think bacteria, diet, and saliva. That should just pop in your head. And I'm looking at bacteria. His teeth look pretty clean. I don't know what his diet's like yet, but we're going to talk about it. I see saliva. So even though he's taking medications that may contribute to xerostomia, looks like he's got, a reasonable amount of saliva. I'm looking at the rest here. We got a lot of tooth structure missing. Now, what's happening here? And so as we go to his risk assessment form, we're talking about that. I'm starting to ask him, this looks like acid erosion to me more so than caries. And all the tooth structure is hard. And look at his teeth in the next picture. I've got a low biofilm challenge. So we have a bacterial issue here. His is pretty normal. He's taking some medications that may contribute to xerostomia, but he looked like he had an adequate amount of saliva. So I'm kind of going through the usual suspects there, and I'm kind of coming up blank. And now I'm starting to think, well, how's the reflux? And he answers negative. He's been tested for it, and he's negative for that. So here's the appearance of his teeth. Now, a lot of people in our profession would misdiagnose this as bruxism. And I'll tell you, this is categorically not bruxism. They have true bruxers they absolutely wear them flat. You don't have sharp points of enamel with dentin missing in the middle. These teeth would be worn absolutely flat. These look like blades here. So somebody that was grinding their teeth at night or function would not have an appearance that looks like this. So we're looking at an acid erosion case. So now I start probing in, we start thinking about that. So if you're not having any reflux, you've been tested for it, and again, you can see the saliva bubbling in the back of his mouth. His diet appears normal. Like I'm asking him about, do you suck on lemons? Do you hold these things in your mouth? Do you drink a lemonade during the day? Grapefruit, do you eat grapefruit? I'm starting to look for environmental acid or dietary acid, so tell me more about your diet. Tell me what kind of things you drink. Tell me what an average day looks like for you. What would you breakfast? Tell me about what you would have for lunch. Tell me about what you would snack on. Tell me about what you'd have for dinner. And I got to tell you, we're coming up blank. We are coming up absolutely blank. And I'm looking at this and I'm thinking, I have no idea, but something really serious is going on. And he said that this has really been progressive, and it's happened over the last 7 or 8, 9 years. And most of his teeth are just slowly dissolving away. Looking at this, scratching my head, and I'm going, so tell me environmentally, where do you work? What kind of job do you have? He says to me, I'm a brake specialist. That's interesting. What does that mean? I work for a company, and I primarily work on brakes, on equipment, drill equipment. I'm going, okay, so are you exposed to a lot of acid in that process or abrasive? Is it abrasive, the environment? And he says, no. And I said, what kind of things do you use? I use brake cleaner fluid. I don't know if anybody here tonight with me has ever used brake fluid, but I've restored. I love Mustangs. I've had about 5 or 6 over the years. I've restored them, and I've worked with brake cleaner, brake fluid, and it comes in an aerosol can. And I got to tell you, this stuff dissolves everything. And I haven't tested it for the pH yet. I need to go do that. And it comes in an aerosol. And I mean, literally, when you're working with that stuff, you can spray it on it gets gunk off. I mean, it literally just doesn't put near it. And I think it's an organic solvent. I really don't think it's that acidic, but it has a particular odor. He says, I love the smell of it. I go through about a case of it a week. I'm convinced that what's going on here, the usual suspect, is that question mark over on the side. We're talking about acid erosion here, erosion, dissolution of his teeth, and I really think that that's occurring from a solvent, that this aerosol that he's been exposed to at his work every day. I've not seen another patient like this. I've showed this case to several colleagues and had everybody scratch their head the only that I can come up with. So we're not really talking about dental caries here. We're talking more about acid erosion. And you're going to see cases that have they may have some dental caries along with the action that you see, and you need to really determine, is this a dental caries issue, or are we just talking strictly about acid erosion? And I thought this was a really interesting case. Diagnosis here for me, I think that this puts him at moderate risk. He certainly has risk factors. He has a film challenge. He doesn't have, these are all just strictly acid erosion. The dent is all hard. We've got a massive loss of tooth structure, going to be kind of a restorative issue and a challenge, and I really want to get my brain around where we're going with that before I make long-term recommendations for him. But anyway, I thought this was an interesting case, just one more for you to file away. Sometimes you're going to see cases that are a combination of caries and acid erosion, and you need to start making a decision. Is this a function of the acid erosion? Where is it coming from? Or is this a function of risk and dental caries? So I have a bonus case I threw in there for you all tonight. And it is a moderate risk. A 47-year-old female taking medicines for high blood pressure, levothyroxine, taking vitamin D, B12, intermittently. Blood pressure is a little bit elevated. Recommended they go back and kind of get that rechecked and discuss that with their physician. But again, I want to start talking about when immediately start asking yourself usual suspects, bacteria and saliva. So I'm looking at the teeth. I'm like, my teeth look pretty clean to me. If all my patients had teeth that looked like that, I'd be pretty happy. So I'm not thinking bacteria is an issue here. I immediately start to think about the tissue looks wet, so I'm thinking, what else is going on? The mouth, and I'm not. And I you here is a person that we have a bad margin on tooth number 18. There's some decay there. It's a function of a margin on that crown that doesn't fit. I really don't think that's an issue of dental caries, so I'm not going to, in my mind, that's not a new lesion. Doesn't have lesions around any of the other margins on her crowns or other restorations that all appear sound. She hasn't had any decay in the last 6 or 7 years. So I'm looking at that thinking that's really a function of an ill-fit margin rather than a carious lesion. So as you start to look at some of these cases, you need to make a decision. Is that an initial carious lesion? Is it new? Is it a concern? Or is that something that, is not a concern to you? So as I look through the mouth, they've certainly got a decay history, haven't had any new lesions in a number of years. I think the patient told me 7 years, and the one lesion there, I'm going to replace that restoration for her, but I think it's a function of the fact she has an ill-fitting restoration. So as we look at risk assessment form, she's interested in talking about it. She's maybe interested in changing her diet, and we start to look at, are you taking medication? Yes, this patient's taking enough medications, and all those to xerostomia, so I'm thinking immediately saliva, although the tissue looked pretty wet. And again, then I start asking, we look at, tell me about that. What do you drink instead? She drinks a lot of soda, but typically she drinks diet soda, so I'm like, okay, I'm kind of okay with that. That's better than drinking sugared soda, but something, again, that we want to discuss long term. I'm thinking in my mind I've got an agenda to help her get back to water rather than that. And she is a snacker. She's been a snacker her whole life, and she snacks on crackers, a lot of different issues there. So she's snacking kind of pretty frequently throughout the day. She's been on Metafast type diet in the past, but she's continuing to snack. Now go down to the indicators. Yes, she has a disease indicator there. For me, that's not a concern at the moment as we get into our but does have a lesion. Typically, I would put no on that instead of the yes that you see written there. She does have a high biofilm challenge. So this is somebody that great patient that you have an opportunity to really make a huge difference for. So this is to apply some critical as you go through this with this patient. Here's a patient that has pretty clean teeth, looks to be taking pretty good care of themselves from home care. Risk factors are a concern to me, primarily the potential for xerostomy. The snacking issue is something that we want to talk about. The disease indicators are not a concern to me. I really don't think that if she appropriate margin on that restoration, I don't think that she'd have a lesion there. So that's not really a concern to me. She does have a high biofilm challenge. So as I look at this and start thinking about usual suspects, I think diet and saliva. So how are you going to talk about those issues with the patient? I can't take her off her medications, so we're going to address the fact that this is kind of a combination of a couple of different things going on here. And I really think in terms of diagnosis, this is a person that's high risk, but they're type 3. They have a high biofilm challenge, but they don't really have a lot of disease indicators so that are concerned to me. So this is really a person this is the perfect person to catch, because left in this situation with a high biofilm challenge, they're disease indicators at the moment, but it doesn't take much to continue to tip the scales for this individual, and she might show up with 3 or 4 new cavities, or maybe a very large progressive lesion on one of her bridges or restorations that could occur within a matter of 3 to 6 months that could happen quite rapidly. So here's a person that you want to sit down and counsel with the diet. Again, make simple recommendations. Let's just try and keep it simple. Keep a glass of water by your nightstand. Maybe recommend Boost spray along with some other products. And then talk about the simplest thing that you could do is either rinse your mouth out with water after you snack, or take a couple of squirts of a spray like Boost. So those issues that you can talk about with the patient in terms of coaching. But there's one that was a combination. It was a combination of both diet and xerostomy. I think they're both playing a role. But this person has a biofilm challenge, and this is something that I think this person is certainly at risk for this disease, and really would recommend that they look at doing some antimicrobial therapy if they wanted to recommended approach. And we'll get into that on our next series of webinars, but specifically, what do you recommend and how do you stage that? So next patient, number 6. I'm looking at teeth, and immediately again, usual suspects: bacteria, diet, and saliva. And I'm thinking, wow, teeth again look pretty clean to me, and I'm showing you a lot of clean teeth here so far tonight, but I'm looking at pretty clean teeth. I don't, taking any medications, so I'm thinking, I see saliva bubbling and pooling, so I'm thinking, so xerostomy, saliva is kind of off the table. If she has any problems, I'm going to think it's probably related to diet. So I'm thinking that right out of the gate. I'm looking at the radiographs. Now, I mentioned earlier to you that when we look at the radiographs, you're going to see a lot of interproximal radiographic radiolucencies on this person, right? I mean, I'm looking between 2 and 3, 3 and 4. Let's go over to, let's see, 12, 13, 14 look okay. But I get around to like maybe distal of 20, certainly between 30 and 31. Interproximally, we've got some stuff going on there. Now, those radiographic radiolucencies are E1 lesions, or maybe E2 at worst, but we don't have any D1 lesions here. Let's see, maybe the distal of 19 as I look, closely. So look at this. This has radiolucencies. I don't know how active this is. I don't know how long they've been there. This is a new patient. But I take a shot in time, look at this, and I go, okay, so we have some issues here. I want to start talking about revitalization to this patient, but these are not yet disease indicators. Sometimes get the questions from, practice. When is that cavity or that radiographic radiolucency, when does that become a disease indicator, and when is that a concern to you? And so I'm hoping tonight by sharing these cases with you that starts to make some sense. So start to look at the risk assessment form. Yep, they're interested. They're willing to have the test. They're willing to talk about it. Potentially want to talk about their risk assessment or their modifying their dietary habits. As I'm going down the risk factors, the ones that pop out at me are: do you drink liquids, more other than water, more than a couple of times a day, and do you snack between meals? And so, I'm looking at this patient in the chair thinking diet, and I'm looking to the risk assessment form, and it's like that confirms I was going with the usual suspects here. That's interesting. Tell me about that. What do what things would you say on a normal day you would tell me what it's like in terms of what you drink? So this person drinks a lot of coffee. Do you put in your coffee, right? Do you like it? Do you like it with sugar? Do you use any other NutraSweets or any of the other saccharides, any of the other kind of artificial sweeteners? No. Okay. And you like to snack? How often do you snack? Well, a couple times during the day, and typically I'm snacking on like crackers, like Cheez-Its or something like that. Okay, that's interesting. So thinking, well, not a lot of sugar there. You are snacking only a couple times a day. Let's go back to the coffee. So tell me, how do you drink your coffee? Do you drink it black? I mean, are you drinking the coffee? Tell me about that. Well, she's drinking coffee pretty much periodically and regularly and frequently throughout the entire day while she's at work. Well, I like to use creamer in it. Oh, that's interesting. Tell me about what kind of creamer you use. And this may be something that you know or don't know, but many of the creamers, particularly the dry creamer packets and stuff on the market, have sugar in them. So they're sweetened. And so, yes, this person is in fact using a creamer that has sugar in it that sweetens the coffee at the same time. So, this brings up, I'm going to get into another patient. It brings up a great topic that patients may be taking sugar that they're not even aware of. So when I said that, if it's a dietary issue, typically they either have too much sugar in their diet, and it might be a hidden sugar that they're not aware of, or they're snacking too frequently. So those are typically the two dietary challenges that I see when we break it down to the usual suspects. So if this person, she's getting too much sugar in her diet, and she's just getting it through the artificial creamer. And I mean, if you start reading the labels of these flavoring agents that people put in their coffees, there's a lot of sugar in some of those as well. So those are the things you need to be really careful about in terms of helping patients identify where that's coming from. And again, I like to have the conversation with the patient. It's not the sugar per se. This is Philip Marsh's research. It's not the sugar that's causing the problem here. It's the fact that these bacteria metabolize that sugar into acid. The acid over a prolonged period of time selects for the acidogenic bacteria, aciduric bacteria that cause dental caries. And so it's a function of the biofilm-produced acid that then creates an environment that creates the shift in the mouth toward an acid-uric environment for those bacteria. So let's talk about, with that for the patient as we talk about coaching and we get into that, how can we change that for you? What kind of changes can you make so that, something that's easy for you so that we can be successful at this? I don't want you to stop drinking coffee, but let's start talking about how you're drinking your coffee and what kind of creamer that you're using with it. So the creamer is a big issue. Disease indicators, she does a high biofilm challenge. So when we get down to the risk or to the assessment, the professional assessment summary, then the risk factors are concerned to me. She doesn't have any disease indicators. Those lesions are not D1 yet. But here again, here's a patient that if those are active and she's progressing on those, I haven't had the opportunity to determine that yet, but we have the opportunity to remineralize that. So for the patient, you could root them into recommended therapy would be antimicrobial treatment because she has a high biofilm challenge. I don't do any restorative dentistry because she doesn't need that yet, but I need to get the biofilm under control, and then I need to help her have the opportunity to maybe remineralize those lesions so that they don't progress, and maybe we can get them to reverse. So suspects here, diet, and the hidden sugar in the creamer, and the amount of coffee that she's got going on. This is a type 3 patient. They have a biofilm challenge and risk indicators, but they don't have any disease indicators yet. Here's patient number 7, and this is an 8-year-old female patient that came to me. She's taking medications again for high pressure, taking a Tylenol, taking a baby aspirin every day, blood pressure in the range, systolics just a little bit high. Pulse is okay. So her general health is okay. I'm looking at the teeth and I'm thinking, I see. Again, teeth look pretty clean. I'm seeing some lesions there around on the class 5 area of of number 10. Maybe, certainly we've got a recurrent lesion around the distal of number 8, crown on the class 5 area on number 20. So I'm looking in the mouth. I'm just looking. I'm seeing, yep, I'm seeing some lesions. I see some saliva, a little bit of saliva in the back. The tissue in the front, though, looks a little dry to me, particularly, above the maxillary incisors. Actually looks pretty dry right there. Okay, saliva is a question for me, and I'm thinking diet. So those are the first two things I'm looking at. I'm not seeing a lot of decay underneath the restoration there. Not seeing a lot of new initial lesions going on. Radiographs, but certainly you can see those going on in the mouth. History of decay. So when we look at this, here's a patient that said yes to all of the above. Does hold up, is taking multiple medications. She has a dry mouth. That's interesting. Tell me more about that. She tells me that she wakes up 2 or 3 times in the night, and she's a mouth breather, and her mouth is absolutely bone dry. And she keeps, something on her nightstand to take a drink of, and mostly that's water. She tells me, so that's a good thing. But certainly, that a patient self-reporting xerostomia is an issue that you need to think about. She has visible cavitations when we get to the disease indicators. No white lesions and no interproximal radiographic radiolucencies, and decay history is a concern to me. And low biofilm challenge. Now let's look at this. Here's a person who's got decay going around in these class 5 areas, but doesn't have a high health challenge. So as we get down to her professional assessment, are a concern to me. The fact that she has a low biofilm challenge tells me that it's not going to help her to put her on an antimicrobial agent. She doesn't have a bacterial issue here per se. Primarily, what's driving or fueling this infection for her is not too much bacteria, but the fact that maybe she doesn't have enough saliva or doesn't have enough buffering capacity going on in her mouth. So in my mind, the usual suspect here is the saliva. Diagnosis, she's type 4 high risk. So I want working in terms of her with the xerostomia that she's got, recommending a neutralizing agent for her to use during episodes in the day or maybe at night to help raise the pH back up, replace some of the function of the saliva. If you continue to see cavities develop on somebody that has xerostomia, you may want to put them in a tray at night that has the CTx 4 gel 5000 in it, something like that. I'll use that if I need to, but I would start out with just trying to recommend, using products going to help neutralize the mouth during the day, raise the pH back up. The patient understand probably the best thing she could drink during the day is just water. Be the thing for her. So patient number 8, and I'm looking in the mouth here. This is a 31-year-old male, new patient, not taking medications. Blood pressure is okay, pulse is okay. In fact, pulse is a little low. This guy's an athlete. He works out a lot, plays baseball. Pretty. I'm looking at. Looks like the person that chews tobacco here. So we got that going on because we got some gingival stripping there. We see the there on the lower lip. So you got all the telltale signs that going on. I look in, I see a lot of lesions. I don't see an abundance of bacterial plaque buildup, so I'm thinking immediately, not bacteria. I'm thinking saliva here. Tissue looks wet. I'm thinking diet. So as I sit down and talk to this guy, that's where I'm kind of heading with this. So got some, certainly got a tooth number 12 there that wasn't restored, or maybe it had a crown on it, but I don't think it ever got restored. Was his response? It certainly had a decay history. He's got a lot of restorations in his mouth. I think there's a lesion, a occlusal lesion going on there underneath number 30 from what we can see, and certainly have a lot of class 5 lesions going on. So, male. I went to the question, and the patient said no. No, I'm having a free test. Now, it was interesting to me. He went ahead and filled everything else out. And so here's what we get. Here's what we learn on this patient. He's talking about it, but he's not having the test. Okay, doesn't come down for me, but okay. And if needed, he's willing to talk about modifying his dietary habits. So we get down, I start looking at risk factors, and it's yes, I drink liquids other than water more than 2 times a day between meals. That's interesting. Tell me about that. And so when I start asking, he's using a lot of the sports drinks, vitamin water, Gatorade. The guy's an athlete, and these are apparently healthy for you, and so he's thinking these are good, so that's what I'm drinking. Aside from the opportunity for them to be acidic, a lot of them have a lot of sugar in them as well. So you really need to talk to your patients about what it is that they're drinking, and let's look at the pH of that, and is there sugar in there? Certainly Gatorade, sucrose is the #1 agent listed after water. So, it's fine for carbohydrate loading. It's fine for athletic events. It's not something that you want to drink throughout the day, continuously throughout the day. In fact, I don't know if anybody caught this while I was working out this morning on Fox Morning. They got a 5-minute expose on sports drinks and talking about the fact that these things are acidic and they're bad for your teeth, or potentially bad for your teeth. So it's finally somebody starting to talk about this, and it was on Fox News. I watched it while I was working out. So, and typically it's like a 30-second blurb. This thing was like 4 minutes, and I was really impressed. It was very well done. They interviewed the president of the Academy of General Dentistry. They interviewed the research. There was a new paper just published. They interviewed the lead researcher, and it was a very good educational piece for the public. But now take this patient, and he does admit to chewing tobacco every day. So this is what we have to work with. Below the patient, patient declined doing anything else about this. I don't know if he has a biofilm challenge or not. I mean, he could be at decay, so that means as we look at the risk assessment, we have visible lesions. So risk factors are a concern. Sports drinks, disease indicators are a concern to me. We've got visible lesions. We've some white lesions. Certainly he's had decay in the last 3 years. His history is a concern to me. Radiographs, I didn't see any interproximal radiolucid, but in the biofilm challenges, that's an unknown to me. So if you're using a meter, you come down to the point where whether it's a biofilm challenge or not. Now, why is that an issue? It becomes an issue because, as I lose usual suspects, I'm thinking diet. It's a question mark, but I'm thinking diet. I think drinks, but now it becomes the diagnosis. He has disease indicators. So type 4 or type 5, but I don't know whether he's a type 4 or type 5. If he were type 4, that's a low biofilm challenge, and I don't need to put him on an antimicrobial agent. He's going to benefit from antimicrobial therapy. In the past, the gold standard when I started doing this 12 years ago, these people all got put on chlorhexidine. You got a cavity, you got put on chlorhexidine. It didn't work for some patients. Well, those patients didn't have biofilm challenge, so an antimicrobial agent wasn't really the correct therapy for them long term. Now, if he does have a high biofilm challenge, he doesn't seem to have an abundance of bacterial plaque, but he may have an abundance of the wrong bacteria, and he may have a high biofilm challenge score. He may have a high ATP reading, and that's the person I'm going to want to put on an antimicrobial therapy. So that depends upon what, right there, what kit I would move to. So that data, I don't know. I thought that was a real interesting case because you're going to get cases like that. This is a 27-year-old female. Looking at the teeth, I'm starting to see some plaque on the teeth here for a change. I see lots of saliva that's going on, and I see a broken tooth. I think there's probably decay there. When we look in the radiographs, we see a lot of decay going on here. A lot of interproximal radiographic radiolucencies that are D1s and D2s. So as we go through the risk assessment form, do you drink liquids other than, here's her risk? It's diet, right? And I'm thinking plaque. I'm thinking about bacteria. So I'm thinking back to diet. We go through, she's got all of the risk disease indicators. She's got factors that are concerned to me, and she has a high bacterial biofilm challenge. So I went into the assessment, and I'm asking her, well, what? Tell me that's interesting. Tell me more about that. Soda. Sweet things, and I think we've got an issue with home care. So we've got a number of different issue going on here. And as I talk to the patient, we look at usual suspects, diet and bacteria, or we could say bacteria and diet if you wanted to put it that way. But certainly bacteria is an issue for her. I'm going to put her on an antimicrobial therapy. We're going to start changing some of the products that are in her hands. But now we've got several things that we need to work on. We need to work on brushing and flossing. We need to work on modifying her diet. The fact that she's drinking regular soda and the fact that she's snacking frequently on sweet things. So we've got 4 or 5 different issues here to handle. Start with the antimicrobial agent, and then I'm going to ask the patient, what do you want to start working on? So it's going to be a great case for us to follow together. We're going to do that, and we're going to look at what the patient decides to do. We're going to see how that turns out long term. So this will be a great case for us to follow later on in this year. So these are all a concern to me. So this person has everything. They're a type 5. They're high or an extreme patient. This is a person that you want to get into antimicrobial therapy. I have to tell you, I didn't get photographs today, but I saw them today. And I have to tell you, so here's a 61-year-old male, new patient that comes to me, wants to save his teeth. That's what tells me. So he's taking lisinopril, he's taking hydrochloroquine, blood pressure, systolics, he's pretty high. I've talked to him about going to see his physician to, check his blood pressure and start talking about, maybe that isn't under control. Think of this, bacteria, saliva. Well, I see a lot of bacteria on the teeth. So, number one, bacteria is an issue here. Too much bacteria. I can tell you out of the gate, we got a problem. Diet, I don't know what his diet's like, but saliva, he's looking a lot to me. Around the teeth, I don't even see much saliva in the back of his mouth. So I'm thinking we got a couple of issues going on for this guy. Look at the radiographs, got major disease indicators going on, got some cramps that he had that are gone. Major. He wants to save his teeth. He's 61 years old, and so I don't blame him. So I look at this, we go through it. It's like yes, maybe. I'm looking at disease indicators. Yeah, he knows he's got a lot of plaque on his teeth and it's building up. He's taking number of medications, he's taking medications, and those can lead to xerostomia or contribute to that. He's drinking coffee a couple of times during the day. He drinks it black. I'm not really too concerned about that. He snacks between meals. We get down to he snacks maybe once or twice a day, and he's snacking on things that aren't too much of a concern to me. So as I'm going through these, he's got the usual risks or the usual suspects. I'm thinking bacteria and saliva. Diet isn't that big a concern to me right at the moment. Now, as I look at all of his disease indicators, he's got everything but white spot lesions going on, and his bacterial biofilm count is 8105. And he smokes cigarettes. I'm going to guess, about 2 packs a day is where we're at. So we've got a lot of issues. Here's a person that we got a lot of things a lot of opportunities for change. I'll put it that way. So as we look at the professional assessment summary, risk factors are concerned, disease indicators are concerned, high biofilm challenge. This guy has it all, usual suspects, bacteria, and saliva. So he's got a combination of, we need to work on home care and start talking about the bacteria, antimicrobial agents and therapy, and we're going to need to work on help him deal with the medication-induced xerostomia. So here's a type 5. He's high and extreme, and I have to tell you, I saw him today. He's finished the root planing. His teeth are clean. We've only worked on 2 things for him. We started on microbial therapy, and I absolutely patted him on the back today. He got 2 gold stars. I was impressed with the turnaround that he's making in the last 2 months in his own health. So, you have to celebrate those kind of victories with patients and really commend them for the good work and the hard work that they're doing. So I was really tickled to see that. Here's your bonus patient for tonight, and they're going to be done. So this is patient number 11, 14-year-old female. Patients, pressure, what you'd expect for a 14-year-old. So I need to think immediately, bacteria, diet, and saliva, right? Bacteria. Teeth look pretty clean. Doing a pretty good job on her home care. I'm okay with what's happening here. Diet, I don't know yet. she's got an abundance of saliva. Everything's wet and it's bubbling in the back of her mouth. So that is looking good. Now we're looking at this, and I'm seeing interproximal radiolucencies. She's got between up on 12 and 13, and certainly other teeth. We have some D1 lesions going on. We have an abundance of E1s, E1 and E2 lesions. In fact, literally interproximally between all of her teeth, she's got demineralization occurring, E1, E2, or even D1. So as I look at this, start thinking about this. 14-year-old girl. I mean, you guys see these patients. This is not rocket science. As we go through there, doesn't the second question, and I mean, these are real answers. These are real forms. You know, maybe talking about modifying her dietary habits. We go down through there. She does not list any risk factors. She doesn't snack between meals. She drinks a lot of water. She doesn't drink soda. She's not taking medications. We go down through this, and you look at this and go, okay, and she has a high biofilm challenge. So what's going on? New proximal radiolucencies. Her decay history is a concern. When we go to the risk factors, the assessment, risk factors are a concern to me. Well, she didn't report any risk factors. But what's going on here that concerns me? She's got disease indicators that are a concern. She has a biofilm challenge. Suspects. It's got to be in her diet, right? What's going on here? These things healthy don't look like that. You know, I mean, it's like something's happening here. 14-year-old girl, what is a normal, typical habit for a 14-year-old girl? You chew gum. Tell me about that. Oh, she chews gum. She chews gum all along. She chews gum in between classes and tries not to get caught. She loves gum. That's interesting. What's your favorite gum? And what? It's not a sugar-free gum. So here's the issue. She's got sugar. She's had these frequent hits during the day. And so literally for this person, I want to start on an antimicrobial therapy. We want to eventually work on remineralization on those lesions. I've got a couple of those that I'm going to have to restore. But we need to talk about if she wants to make behavioral change and flying in a com. I mean, we got those. So we got 4 things. You know, I want to work with her. I want to bombard her with all of those today. I want to start with the antimicrobial therapy, and then next one, the behavioral change I want her to work on is the gum chewing. Don't give up gum. Let's go to xylitol gum. Let's go gum that's going to be actually beneficial. In fact, I want you to chew this gum. Her eyes light up when I said, no, I don't want you to stop chewing gum. I want you to chew gum. I just need to have you chew gum that has xylitol in it. And so it's like, I mean, it's like I can do that, right? So as you go through these cases, you start to look at these things. It's rocket science. Start to look at the usual suspects. Think back to diet and saliva. These things will start to come together for you. It's not that hard. It's not rocket science. She's high in extreme risk. So that was 11 cases that we went through today. I gave you a lot of information again. I think hopefully some different cases. But again, I think you get a feel for, you know, get a lot of patients. Typically we come back to pretty consistent suspects. There's a pretty consistent theme. Old patient, you can pretty much count on xerostomia. A young patient like this, you can pretty much count on a dietary or a bacterial issue. If it's a guy and he's an athlete, you can pretty much start thinking sports drinks. I mean, it always doesn't pan out that way, but there are a lot of trends that you're going to start seeing when you do this over a period of time, and it'll get easier and easier for you. Your takeaway tonight is, tell me about that. That's the thing. Tell me about that. And patients will open up and talk to you about what's going on. And I got to tell you, that's the most powerful you can use when you start talking about risk with these patients. So I really want to thank you tonight. As we continue on this series, we'll continue diagnosis with cases, but I'm going to start getting into, let's talk about what do we do next. Okay, we have all these patients, they have all these issues. Really, let's get down specifically what comes next, how do we stage treatment, what first, what should we do second, and then we're into behavioral management and coaching. Thank you. I ran over tonight. We've got time for a couple of questions, and about anybody that's new and wants to get started, they do that. So, Kendall?
Yes, absolutely. Thank you, Dr. Kutsch. Those cases were awesome. And also thank you to everyone for your great questions. We have quite a few coming in, so we'll get started, get through as many as we can. And if you obviously need to break off the phone, that's totally fine too. So the first question we have, I'm not always confident in knowing if I should be concerned about certain risk factors. How do you determine if you are concerned or not?
That's a really great question, and I wish I had a really simple answer to that. And let me re-ask the question, Kendall. Was it about disease indicators or risk factors?
Factors.
Okay. So I'm pretty much concerned about most risk factors with that. Whether it is a dietary issue or the patient notices a plaque buildup, if they've got risk factors, typically become a concern to me because it puts the patient at risk. So I'm thinking of a risk factor that wouldn't be a concern to me. What about, a risk factor like the guy drinks coffee instead of water? He drinks black coffee and he drinks it twice a day. Okay, but that's not a concern to me. Yeah, it's acidic, but that in itself typically isn't enough to tip the scale. So how to get to that point, a lot I think is just common sense, like, do you have a good idea for the patient? Do you think that's putting the patient at risk? It isn't, again, it's not rocket science, but it's not black and white either. And so there is a critical thinking component to this for you to ask yourself, just common sense, is that a good idea? And if it's not if it's not something you would recommend for your children to do, if it's a concern, if your child was doing that and that would concern you, then I think that's a concern for the patient. That's the best way that I could phrase that. Or if somebody in your family was that something that you'd be concerned about? Then if you think it's something that's going to contribute strongly to the disease, then it's a concern. Not something that you feel is contributing to the disease, and it's not a concern. And that's not the best way that I can answer that, Kendall, but it's a great question, and I don't have a simple black and white answer for you, but it's something that as you continue to do more and more of this, you'll get a real comfort zone, and I'm getting reports back from a number of practices that I'm coaching that actually we're into this a couple of months. We're doing this consistently, and we're using the meter on every patient, and it's starting to make sense to us. And I'm getting more and more comfortable with what those readings are, and I have greater confidence, and I'm feeling more comfortable about my decision making on helping answer those kind of questions. So it's really something that just will come with experience, and be patient. But certainly, if you have a question on that, on a case, Kendall, you and the entire team here are the most experienced people I know to be able to answer those kind of questions as coaches for practices as they come up. So if you have a question, we are all a resource to you. Thank you, Kendall.
Mm-hmm. And I think we will probably stick to just a couple, but I will do just at least one more. So how do you set realistic expectations with patients for treatment time? Use motivational interviewing techniques when it may be something they need indefinitely. How do you approach that conversation?
And that's another great question. I approach it like you would if it's something that I'm going to need to have them on. Let's say they have xerostomia. Let's just pick one. They've got medication-induced xerostomia. That change. Live, and they're taking those medications, which they probably will be. They're going to continue to have medication-induced xerostomia. So whatever I'm doing to try and help balance that and keep them healthy in a healthy balance, as long as they have that risk factor, we're going to have to do that for the rest of their life. So it's like that may mean using the CTx4 Gel 5000 for the rest of your life to help accommodate that. If their patient has severe xerostomia and you've got them in a tray, it takes a tray with that gel every night to keep in a healthy balance, that may be for the rest of their life. And it's like if they understand the medication is causing the problem and they're going to continue to take the medication, they have to understand. I mean, I think all the patients I've talked to about that, they're very open to understanding. It's like, oh, well, I need to do this as long as I'm taking that medication. That makes sense. In terms of the behavioral change issues, in the past, and so this is a voice of experience coming to you here tonight, but it's like I would try and change too many things and do it too quickly, and it doesn't work. And so it's like trying to get you all cured and healed and pat you on the back in 6 months. You know what? If we've got 4 or 5, like I showed you patients tonight that have 4 or 5 issues that I'm going to be working on, I'm telling the patient, it'll take us a couple of years to accomplish all of those. But you know what? That's okay. And it doesn't matter how long it takes. We're going to work on them one at a time, and we're going to do it on a pace, and you're going to be successful at it because our patients are, and I know how to coach you through that. And I don't care how long it takes, but don't expect it to happen in 3 months. And I got some patients that are going to make it happen in 3 months, and I've got some patients that may take 5 years. And that really goes back to how motivated they are and how disciplined they are in terms of behavioral change for themselves. So it's like, I don't want to set any expectation that I'm going to have you cured in 3 months or even in 30 days, which I used to do. I used to try and help that patient think that they would be healed in 90 days. That, it didn't work that way. I'm more comfortable with, this is a long-term project that we're starting here, but we're talking about you being healthy and having your teeth for the rest of your life. And we've got a lot of issues on the plate. I just want to break them down. It's the old, how do you eat an elephant? You eat it one bite at a time. Let's start with one bite here today, and then we've made progress. And we'll just continue to slowly make progress, and it's going to work. So we'll get into that specifically as time goes by, but if I would give you the short answer to that today, start thinking more longitudinally in terms of your approach to patients, and don't try and create expectations for them that they're going to be cured overnight. This is a biofilm disease. Biofilm diseases are the most difficult diseases to treat. They don't respond well to much of anything. They're, really the hardest to treat. And dental caries is the #1 disease worldwide for adults and children. And the reason for that is it's a difficult disease to treat. So what we've got works well, and I think we have a system that you can integrate and implement into your practice fairly easily, and it works well with patients. So we've got 12 years of experience, to get to this point. But again, it's still going to take time to get patients through that process. So be patient.
Mm-hmm. That's a really good point. If you're doing risk assessment, and you can answer for the patient why they are experiencing that treatment time conversation is a lot easier than just telling them that they have to be on treatment possibly forever. If they know why they may have to be on treatment forever because of the risk factors that we've identified, I think it's an easier conversation too. So I think that's a really good point. So I know we have run over just a little bit, and before we wrap up, there are just a few last things that I wanted to get out to you guys. So thank you to everyone. I know we weren't able to answer all of the questions. Again, we will be replying to them throughout the week via email. For those folks who are new to CariFree and interested in getting started, the Level 1 package that's seen here on the screen is what we would recommend getting started with. It is intended for those offices that would like to maybe start small, just begin introducing this to the patients in their practice who have those suspects that we were talking about tonight and would greatly benefit from some sort of treatment. If you are a current customer, you're also more than welcome to take advantage of this offer. There is a discount code, as you can see on the screen, that's associated with it, which will save you over $100 on the package. So if you would like some more information, feel free to give us a call. Our number here is 866-928-4445. We would be more than happy to help. And thank you for sticking with us, and we hope you guys have a great night.
Thank you. Great evening. It's really a privilege for me to be able to share this with you.